my respected brothers and sisters. My name is Dr. Fahmy, and today I'll be guiding you through an exploration of orthopedics, covering everything from inflammation and infections of the bones and joints. Throughout this presentation, I encourage you to take notes, engage with the material, and envision yourself as future leaders in the field of orthopedics. Together, we'll delve into the fascinating world of musculoskeletal health and explore the latest advancements in orthopedic care. Without further ado, let's embark on this journey together. Now, we delve into the intricate world of orthopedics, starting with a common yet significant condition, osteomyelitis. Let's explore this bone inflammation together. Osteomyelitis, a term derived from osteo, meaning bone, and myelos, meaning marrow, refers to inflammation of the bone, predominantly affecting the cortex and the medullary cavity. This condition typically arises as a result of an infectious process, often originating from distant sites of infection such as the tonsils or skin. Through the bloodstream, pathogens can travel to the bone, leading to the development of osteomyelitis. In simpler terms, imagine your body as a vast network of interconnected roads and bacteria as unwelcome travelers seeking entry. Sometimes, these bacteria hitch a ride through the bloodstream and find their way into the bones, causing havoc along the way. Understanding the mechanism of infection is crucial in diagnosing and treating osteomyelitis effectively. As we progress, we'll delve deeper into its clinical manifestations, diagnostic modalities, and management strategies. Let's delve into the fascinating realm of orthopedic pathology, focusing on the diverse mechanisms of bone infection. Let's explore the intricacies of contiguous, exogenous, and hematogenous osteomyelitis. Contiguous or exogenous osteomyelitis arises from pathogens originating outside the body or secondary to infections in adjacent soft tissues. These nefarious invaders can infiltrate the bone, leading to insidious onset infections. A common culprit in this scenario is none other than Staphylococcus aureus, often introduced through open fractures. The infection stealthily progresses to infiltrate the underlying bones, wreaking havoc along the way. On the other hand, hematogenous osteomyelitis stems from blood-borne pathogens originating from infectious foci within the body. These pathogens, commonly encountered in dental, ear, sinus, tonsil, or respiratory infections, find their way into the bloodstream, seeking new territory to colonize. Once again, S. aureus emerges as the primary offender in this scenario, maintaining its notoriety as the most common pathogen in bone infections. Understanding the diverse etiologies of osteomyelitis is paramount in its diagnosis and management. Whether it's the contiguous invasion from adjacent tissues or the stealthy infiltration through the bloodstream, each pathway presents unique challenges in clinical practice. As we delve deeper into this topic, we'll unravel the diagnostic modalities and treatment strategies essential for combating osteomyelitis effectively. As we delve into the clinical manifestations of osteomyelitis, it's essential to recognize the distinct features that characterize this challenging condition. Chronic osteomyelitis presents a formidable clinical challenge, often persisting despite conventional treatment measures. Clinically, a condition is deemed chronic if it fails to resolve within 10 days, indicating a prolonged and stubborn infection. One of the hallmark signs of chronic osteomyelitis is the presence of significant necrotic tissue on the affected bone. This necrosis, often evident upon clinical examination or imaging studies, serves as a poignant indicator of the severity and chronicity of the infection. Recognizing these signs and symptoms is paramount for early diagnosis and prompt intervention. By identifying chronic osteomyelitis and its telltale necrotic features, healthcare providers can initiate targeted treatment strategies to mitigate complications and improve patient outcomes. Let's now explore the telltale signs and symptoms that herald the presence of osteomyelitis, guiding clinicians in their diagnostic endeavors. Pain serves as a primary indicator of osteomyelitis, typically localized to the site of infection. Patients often describe a deep, throbbing discomfort that intensifies with movement or pressure, signaling the presence of underlying bone involvement. Accompanying this pain is often the hallmark trio of systemic symptoms: fever, swelling, and redness. The body's immune response to the infection manifests as localized inflammation, resulting in warmth and erythema over the affected area. Additionally, patients may experience systemic manifestations such as excessive sweating and chills, indicative of the body's efforts to combat the invading pathogen and restore homeostasis. By recognizing these symptoms, clinicians can promptly initiate diagnostic investigations and therapeutic interventions, aiming to alleviate patient discomfort and prevent complications associated with untreated osteomyelitis. Let us embark on a journey into the fascinating pathophysiology of osteomyelitis, unraveling the intricate cascade of events that characterize this inflammatory bone condition. At the forefront of osteomyelitis pathogenesis lies observable edema at the site of infection, a visible manifestation of the underlying bone inflammation. This edematous response reflects the body's attempt to contain and combat the invading pathogens within the bone microenvironment. As the inflammatory cascade unfolds, patients may present with a constellation of systemic symptoms, including fever, malaise, headache, and sometimes anorexia. These manifestations underscore the body's systemic response to the infectious insult, signaling the activation of innate immune defenses. Clinically, affected areas may appear erythematous, tender, and edematous, reflecting the localized inflammatory response within the bone. These characteristic findings serve as important diagnostic clues for clinicians, guiding their assessment and management strategies. In more severe cases, patients may develop fistulas draining purulent material, representing a culmination of the inflammatory process and tissue breakdown. Such clinical manifestations underscore the progressive nature of osteomyelitis and the potential for complications if left untreated. Furthermore, laboratory investigations often reveal an increase in white blood cell count, erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, levels, indicative of the body's systemic inflammatory response to the underlying infection. By unraveling the intricate pathophysiology of osteomyelitis, clinicians can gain valuable insights into the disease process, facilitating early recognition, prompt intervention, and optimized patient outcomes. Now, let's explore the diverse array of causes that underpin the onset and progression of osteomyelitis, ranging from bacterial infections to less common fungal etiologies. At the forefront of osteomyelitis causation lies bacterial infection, with Staphylococcus aureus emerging as the primary culprit in the majority of cases. This virulent bacterium, commonly found on the skin and mucous membranes, possesses a remarkable ability to invade and colonize bone tissue, triggering the inflammatory cascade characteristic of osteomyelitis. However, it's important to recognize that osteomyelitis can also arise from fungal infections, albeit with much lower frequency compared to bacterial etiologies. Fungi such as Candida and Aspergillus may infiltrate bone tissue, particularly in immunocompromised individuals, leading to a distinct clinical presentation and management approach. Beyond microbial invasion, osteomyelitis may originate from infected adjacent soft tissues, muscles, or tendons, exemplified by scenarios where chronic skin ulcers serve as a nidus for bone involvement. This contiguous spread underscores the interconnectedness of soft tissue and bone pathology, highlighting the importance of comprehensive wound management in preventing osteomyelitic complications. Additionally, osteomyelitis may stem from infections originating elsewhere in the body, such as dental, ear, sinus, or respiratory infections, with pathogens gaining access to the bone via hematogenous dissemination. This hematogenous spread underscores the systemic nature of osteomyelitis, necessitating a thorough evaluation of potential primary infection sites in affected individuals. Furthermore, bone injury, including fractures, puncture wounds, or surgical procedures, may serve as predisposing factors for osteomyelitis development. Trauma-induced disruption of the skin and underlying tissues creates an entry point for pathogens, exacerbating the inflammatory milieu within the bone microenvironment. By elucidating the diverse spectrum of osteomyelitis causes, clinicians can adopt a nuanced approach to diagnosis, treatment, and prevention, tailored to the specific etiological factors at play in each patient's clinical scenario. Beyond microbial invasion and traumatic injury, bone surgery emerges as a noteworthy predisposing factor for osteomyelitis development. Procedures involving the insertion of metal rods or plates, intended to stabilize fractures or correct skeletal deformities, may inadvertently introduce pathogens into the bone microenvironment, setting the stage for infection. In the pediatric population, long bones stand as prime targets for osteomyelitic involvement, with their robust vascularity and rapid growth potential rendering them susceptible to microbial colonization. Children presenting with bone pain, swelling, or systemic signs of infection warrant prompt evaluation for osteomyelitis, particularly in cases of recent trauma or surgery. Conversely, in adults, osteomyelitis often manifests in distinct anatomical locations, with the feet, vertebrae, and pelvis emerging as common sites of infection. These regions harbor unique biomechanical and physiological characteristics that predispose them to microbial colonization, necessitating a tailored diagnostic and therapeutic approach in affected individuals. By recognizing the diverse array of causative factors contributing to osteomyelitis, clinicians can adopt a comprehensive approach to patient evaluation, integrating clinical history, imaging studies, and microbiological analysis to elucidate the underlying etiology and guide therapeutic decision-making. As we unravel the intricate tapestry of risk factors predisposing individuals to osteomyelitis and septic arthritis, we uncover a diverse array of systemic and localized vulnerabilities that converge to elevate the likelihood of infection. Diabetes, a pervasive metabolic disorder, emerges as a prominent risk factor for bone and joint infections, exerting its deleterious effects on both the immune system and vascular health. In individuals with diabetes, impaired immune function and compromised blood flow create a fertile environment for microbial proliferation, heightening the risk of osteomyelitis and septic arthritis. Patients undergoing hemodialysis confront a heightened risk of bone and joint infections, as the process of renal replacement therapy exacts a toll on immune function, rendering them more susceptible to microbial invasion. The compromised host defense mechanisms inherent in hemodialysis patients underscore the importance of vigilance in detecting and managing osteomyelitis and septic arthritis in this vulnerable population. Poor blood circulation, a hallmark feature of conditions such as peripheral artery disease, poses a formidable challenge to the body's innate ability to combat infections in the bones and joints. Diminished perfusion compromises the delivery of immune cells and antimicrobial agents to the affected sites, perpetuating the inflammatory cascade and exacerbating the risk of chronic or recurrent osteomyelitis and septic arthritis. Traumatic events, ranging from fractures to penetrating injuries, serve as harbingers of osteomyelitic and arthritic complications, providing opportunistic entry points for microbial colonization. The disruption of skin and bone integrity following traumatic events creates an avenue for bacterial ingress, amplifying the risk of infection and necessitating prompt intervention to mitigate sequelae. In the diagnostic odyssey of osteomyelitis, a multitude of tests and assessments converge to unveil the intricate pathophysiology underlying bone infection, empowering clinicians with invaluable insights to guide therapeutic interventions and optimize patient outcomes. At the forefront of diagnostic endeavors lies the indispensable blood culture, a gold standard method for confirming the presence of pathogens circulating in the bloodstream. Positive blood culture findings serve as a pivotal diagnostic clue, guiding subsequent therapeutic strategies and antimicrobial selection. Complementing the diagnostic armamentarium is the bone biopsy, a meticulous procedure aimed at isolating and culturing microbial organisms from the infected bone tissue. By elucidating the specific pathogens implicated in osteomyelitis, bone biopsy facilitates tailored antimicrobial therapy and enhances treatment efficacy. Radiological imaging, including bone scan and bone X-ray, assumes a pivotal role in the diagnostic algorithm, offering valuable insights into the structural and functional alterations wrought by osteomyelitis. Positive radiological findings provide tangible evidence of bone involvement, guiding the localization and characterization of the infectious process. Serological assessments, encompassing a comprehensive panel of hematological parameters such as CBC, C-reactive protein, and ESR, furnish clinicians with invaluable biomarkers of inflammation and infection. Elevated levels of these markers serve as harbingers of underlying osteomyelitic pathology, guiding diagnostic prioritization and therapeutic decision-making. Needle aspiration emerges as a minimally invasive technique for procuring purulent material from the affected bone, enabling microbial isolation and characterization. The analysis of aspirated specimens provides crucial diagnostic insights, corroborating clinical suspicions and informing targeted antimicrobial therapy. Augmenting the diagnostic repertoire is the adjunctive use of advanced imaging modalities such as MRI, offering unparalleled anatomical detail and soft tissue delineation. MRI serves as a cornerstone in the evaluation of osteomyelitis, facilitating early detection and characterization of bone involvement. A judicious amalgamation of physical examination findings, including swelling, redness, and tenderness at the site of infection, complements the diagnostic landscape, providing clinicians with tangible clinical correlates to corroborate radiological and laboratory findings. Within the crucible of the emergency department, the battle against osteomyelitis unfolds with fervor and precision, as clinicians harness an array of therapeutic modalities to confront bone infection head-on, ensuring timely intervention and optimal patient outcomes. Central to the therapeutic arsenal is the judicious administration of antibiotics, guided by the discerning insights gleaned from sample cultures obtained from the infected area. Tailored antimicrobial therapy, predicated on microbial susceptibility profiles, serves as the cornerstone of osteomyelitis management, arresting the insidious advance of bacterial pathogens and curbing disease progression. Surgical intervention assumes a pivotal role in the therapeutic landscape, offering a decisive means of eradicating the nidus of infection and restoring musculoskeletal integrity. Surgical procedures may entail the meticulous removal of infected bone tissue, excision of necrotic foci, and implantation of antibiotic-laden beads to facilitate local drug delivery and combat recalcitrant pathogens. Augmenting the therapeutic armamentarium is the innovative adjunct of hyperbaric oxygen therapy, a non-invasive modality that harnesses the therapeutic potential of oxygen under pressure to promote tissue oxygenation, enhance antimicrobial activity, and expedite wound healing. Hyperbaric oxygen therapy stands as a beacon of hope in the battle against osteomyelitis, offering a holistic approach to healing and restoration. As we delve into the labyrinthine realm of osteomyelitis treatment, we confront a landscape fraught with formidable challenges, where the specter of invasive surgery looms large, accompanied by the weighty burden of costly interventions. Yet, amidst these trials, lies a beacon of hope, a therapeutic paradigm predicated on the twin pillars of surgical precision and antibiotic stewardship. At the crux of osteomyelitis management lies the imperative of complete eradication, a steadfast commitment to the meticulous removal of infected bone and soft tissue, coupled with the ardent pursuit of infection control and debridement of necrotic tissue. Through these foundational tenets, we strive to stem the tide of infection and pave the path to musculoskeletal restoration. Central to our therapeutic endeavor is the administration of intravenous antibiotics, a cornerstone of osteomyelitis management. Delivered over a duration of 4 to 6 weeks, these potent antimicrobial agents serve as the bulwark against bacterial invasion, combating pathogens with unwavering resolve. Following the initial phase of intravenous therapy, patients may transition to oral antibiotics, ensuring sustained therapeutic efficacy and continued infection control. Embarking on this therapeutic odyssey, clinicians wield a formidable armamentarium of antibiotics, each meticulously selected to target the prevailing microbial landscape. From the stalwart defenses of nafcillin and gentamicin to the versatile efficacy of clindamycin and vancomycin, our arsenal brims with potent agents, poised to confront the diverse array of bacterial adversaries. As stewards of patient care, nurses stand at the vanguard of osteomyelitis management, tasked with the sacred duty of safeguarding patient well-being through the application of aseptic principles, diligent monitoring, and proactive intervention. Let us embark on a journey through the realm of nursing management, where each action is imbued with purpose and each decision with care. At the heart of nursing management lies the imperative of aseptic technique, a steadfast commitment to meticulous wound care and dressing, ensuring the sanctity of the healing environment and guarding against the insidious encroachment of microbial adversaries. Through scrupulous adherence to sterile protocols, we fortify the bulwarks of infection prevention and foster an environment conducive to healing. Vigilance stands as our staunch ally in the battle against osteomyelitis, compelling us to remain ever watchful for the subtlest signs and symptoms of systemic infection. From the telltale rise of temperature to the subtle shift in vital signs, each cue serves as a harbinger of impending danger, prompting swift intervention and decisive action. In the crucible of osteomyelitis management, the timely administration of antibiotics emerges as a cornerstone of nursing practice, a solemn vow to uphold therapeutic efficacy and combat bacterial invasion with unwavering resolve. Through adherence to prescribed dosing regimens and vigilant monitoring for adverse reactions, we champion the cause of patient well-being and ensure the triumph of healing. Empowerment reigns supreme as we advocate for the restoration of function and mobility, encouraging patients to embark on a journey of rehabilitation and recovery. Through the promotion of range of motion exercises to the fullest extent, we embolden our patients to reclaim agency over their bodies, fostering resilience and fortitude in the face of adversity. As we peer into the looking glass of osteomyelitis prognosis, we encounter a diverse array of possibilities, some bathed in the glow of hope, while others shrouded in the shadow of uncertainty. Join me on a journey through the labyrinth of prognostic considerations, where each twist and turn unveils new insights into the trajectory of healing. Amidst the realm of osteomyelitis, timely diagnosis and prompt intervention emerge as beacons of hope, illuminating the path to improvement and restoration. With vigilant surveillance and judicious treatment, patients can traverse the arduous terrain of infection, emerging on the other side with renewed vitality and vigor. However, the landscape shifts dramatically in the realm of chronic osteomyelitis, where the prognosis takes on a more somber hue. Despite the best efforts of modern medicine, the specter of chronicity looms large, casting a long shadow over the prospects of full recovery. In these cases, the road to healing is fraught with obstacles, and success often remains elusive, even in the face of surgical intervention. For some patients, the specter of amputation looms large, a stark reminder of the devastating toll that osteomyelitis can exact, especially in the setting of diabetes. In these instances, the decision to amputate is fraught with gravity, as patients and clinicians alike grapple with the profound implications of life-altering surgery. In the realm of infection associated with orthopedic prostheses, the prognosis hinges on a delicate interplay of factors: the patient's overall health, the nature of the infection, and the feasibility of safely removing the infected implant. Here, the stakes are high, and each decision carries weighty consequences, shaping the trajectory of healing and recovery. As we embark on a journey through the tangled web of osteomyelitis complications, we find ourselves navigating a treacherous terrain fraught with peril and uncertainty. Join me as we unravel the intricacies of these potential pitfalls, shedding light on the shadows that lurk beneath the surface of infection. At the heart of osteomyelitis lies the ominous specter of bone abscess, an insidious threat that lurks within the depths of infected bone, festering and brewing with the potential to unleash a torrent of pus and destruction. But the perils do not end there. Paravertebral and epidural abscesses loom large on the horizon, casting a long shadow over the delicate balance of the spinal cord and surrounding structures. In these instances, the stakes are high and the consequences dire, as the very fabric of neurological function hangs in the balance. Bacteremia, the silent assailant, lies in wait, poised to wreak havoc on the body's delicate equilibrium. Left unchecked, this insidious invader can spell disaster, leading to systemic sepsis and potentially fatal outcomes. In the realm of prosthetic implants, the specter of removal looms large, a stark reminder of the toll that infection can exact on the body's fragile architecture. Here, the decision to remove the implant carries weighty implications, reshaping the landscape of patient care and recovery. And in the most severe cases, the specter of amputation casts a long shadow, eclipsing the hopes and aspirations of patients grappling with the devastating consequences of advanced infection. Here, the loss of limb function serves as a stark reminder of the profound toll that osteomyelitis can exact on the human body. As we pivot from the realm of bone infections to the intricate world of joint inflammation, we find ourselves immersed in the dynamic interplay between pathogens and the delicate structures of the musculoskeletal system. Welcome to the realm of septic arthritis, a condition characterized by inflammation of the joint, wrought by the insidious infiltration of bacterial or fungal invaders. At its core, septic arthritis arises from the relentless advance of microbial foes, infiltrating the sanctuary of the joint space with malicious intent. Here, the battleground shifts from the hallowed halls of bone to the intricate labyrinth of synovial membranes and articular cartilage. The genesis of septic arthritis lies in the clandestine spread of pathogens through the corridors of the bloodstream, seeking refuge within the sanctuary of the joint. Once ensconced within these hallowed halls, the invaders unleash a cascade of inflammatory mediators, igniting a fierce battle for dominance within the synovial cavity. But the origins of septic arthritis are not limited to the clandestine machinations of blood-borne pathogens. Joint injury and surgical interventions serve as potent catalysts, paving the way for the insidious infiltration of microbial adversaries into the vulnerable recesses of the joint space. As we embark on our exploration of septic arthritis, we unravel the tapestry of causative factors that underlie this complex and often elusive condition. Join me as we navigate the labyrinth of microbial invaders and the delicate joints they infiltrate. At the forefront of our inquiry into septic arthritis lies the pivotal question: what precipitates the insidious invasion of joint spaces by microbial adversaries? Let us embark on this quest for understanding, beginning with the most common sites of infection. The knee and hip emerge as the primary battlegrounds in the war against septic arthritis, their complex anatomy and biomechanics rendering them vulnerable to the relentless advance of microbial invaders. In the realm of acute septic arthritis, the landscape is dominated by the ubiquitous presence of Staphylococcus and Streptococcus, pathogens that wage a fierce assault on the synovial membranes of susceptible joints, triggering a cascade of inflammatory responses. Yet, amidst the chaos of acute infection, a less common but equally insidious foe lurks in the shadows. Mycobacterium tuberculosis and Candida albicans, the perpetrators of chronic septic arthritis, a condition characterized by persistent inflammation and lingering morbidity. Now let's talk about the risk factors of septic arthritis. Our journey commences with an exploration of the impact of artificial joint implants, a double-edged sword that promises mobility while simultaneously exposing individuals to heightened risk. Indeed, the specter of bacterial invasions from distant strongholds looms large, as infections in remote anatomical realms mount incursions into the sanctity of joint spaces, seeding the seeds of septic arthritis. Yet, amidst the cacophony of microbial adversaries, a chorus of chronic diseases emerges: diabetes, rheumatoid arthritis, and sickle cell disease, each a harbinger of heightened susceptibility to the ravages of joint inflammation. The arsenal of modern medicine, too, holds its share of culpability as immunosuppressive medications wield their power, rendering the body's defenses porous and permeable to microbial infiltration. And let us not forget the crucible of trauma and surgery, a crucible wherein the seeds of septic arthritis may find fertile ground, germinating amidst the tumult of recent injury or invasive procedures on delicate joint structures. As we navigate the landscape of risk factors, let us cast aside the shackles of ageist assumptions, recognizing that septic arthritis knows no bounds, its tendrils reaching across the spectrum of human existence, from the cradle to the grave. Let's talk about the signs of septic arthritis. These are the things we should pay attention to in case someone might have this issue. One common sign is fever. When someone has septic arthritis, their body might develop a fever as it tries to fight off the infection. This fever can make them feel hot, sweaty, and generally unwell. Swelling in the joint is another key indicator. Imagine the joint puffing up like a balloon due to the infection inside. This swelling can make the joint look bigger and feel tender to the touch. Joint pain is often present in septic arthritis cases. This means the affected joint hurts, especially when it's moved or put under pressure. The pain can range from mild discomfort to severe, making everyday movements challenging. Now, when it comes to babies, they might not be able to tell us when something's wrong. For them, crying during diaper changes or when you try to move their arms or legs could indicate joint pain. They might also have a fever and appear unusually fussy or irritable. Babies rely on us to notice these signs, so it's essential to pay attention to any changes in their behavior or movements. As we embark on the journey of clinical examination and diagnostic tests for septic arthritis, let us unravel the intricate steps that guide us toward accurate diagnosis and effective management. Our first step in this diagnostic odyssey involves the delicate art of joint fluid aspiration, a procedure wherein a small sample of fluid is extracted from the affected joint for analysis. Within this precious fluid lies a trove of information, waiting to be unlocked. A cell count reveals the presence of white blood cells, an indicator of inflammation, while examination of crystals under the microscope may hint at underlying conditions such as gout or pseudogout. But our quest for clarity does not end there. The microscopic scrutiny of gram stain and bacterial or fungal culture unveils the identity of the elusive pathogens lurking within the joint space. Beyond the confines of the joint, our search extends to the bloodstream, where blood cultures serve as sentinels, detecting the presence of circulating pathogens and guiding our therapeutic interventions. And let us not overlook the role of imaging modalities, such as X-rays, which offer invaluable insights into the structural integrity of the affected joint and may reveal telltale signs of bone erosion or soft tissue swelling. Armed with the knowledge gleaned from these clinical examinations and tests, we stand poised to confront the specter of septic arthritis with precision and resolve. As we explore the landscape of treatment for septic arthritis, let us embark on a journey of healing and restoration, guided by a multifaceted approach aimed at alleviating pain, reducing inflammation, and promoting joint health. Our first step in this therapeutic odyssey involves the delicate balance of joint immobilization and physiotherapy, a harmonious dance between rest and rehabilitation that nurtures the healing process while safeguarding against further injury. To quell the flames of inflammation, we turn to the soothing embrace of cold compress therapy, a simple yet powerful tool that offers respite to the beleaguered joint, calming the fires of inflammation and providing much-needed relief. And as we strive to elevate the joint toward the pinnacle of recovery, we heed the wisdom of elevation, a practice that lifts the burden of swelling, allowing the currents of healing to flow freely through the affected joint. But perhaps the most potent ally in our arsenal is the steadfast resolve to keep the joint still, a commitment to restraint that shields the vulnerable joint from the ravages of excessive movement, fostering an environment conducive to healing. And as we lay the foundation for rehabilitation, we embrace the transformative power of targeted exercises, tailored movements that strengthen the joint, enhance mobility, and pave the path toward functional recovery. Yet, should the shadows of fluid accumulation loom large, we stand ready to confront them with the precision of arthrocentesis, a procedure that drains excess fluid from the joint, offering clarity amidst the murky waters of inflammation. And in the face of adversity, when all other avenues have been exhausted, we dare to venture into the realm of surgical intervention, a last resort that wields the scalpel with precision, carving a path toward healing when all seems lost. As we embark on our exploration of antibiotic therapy for septic arthritis, we are confronted with the formidable task of combating microbial foes that threaten the sanctity of joint health. Join me as we navigate the labyrinth of treatment options, guided by the principles of precision and perseverance. Our journey begins with a steadfast commitment to confront the specter of infection head-on, a commitment that demands nothing less than the full force of antibiotic therapy to vanquish microbial adversaries and restore equilibrium to the joint. In the presence of formidable foes like MRSA or MSSA, we must wield the sword of antibiotic therapy with unwavering resolve, embarking on a journey of at least 4 weeks of intravenous antibiotic administration to purge the joint of microbial invaders. And for those afflicted by the scourge of native joint infection, we must tread cautiously, navigating the delicate balance between efficacy and safety as we embark on a regimen of at least 2 weeks of parenteral antibiotic therapy to quell the fires of inflammation. Yet, in the relentless battle against joint infection waged by the notorious S. aureus, we find ourselves at a crossroads, where oral antimicrobial agents emerge as a beacon of hope in the darkest of times, offering respite to the beleaguered joint with a carefully curated arsenal of antibiotics. And when faced with the daunting prospect of gram-negative native joint infection, we turn to the stalwart defender known as ciprofloxacin, a potent ally in our quest for microbial eradication, administered orally for a duration of 1 to 2 weeks to stem the tide of infection. As a guiding principle, we heed the wisdom of time, a principle that the importance of administering antibiotic therapy for a minimum duration of 2 weeks, ensuring that no microbial adversary escapes unscathed from the crucible of treatment. With these principles as our compass, we stand poised to confront the challenges of septic arthritis with courage and determination, armed with the knowledge that every dose administered brings us one step closer to victory in the battle for joint health. As we venture deeper into the realm of antibiotic therapy for septic arthritis, we encounter a rich tapestry of pharmaceutical allies poised to confront microbial adversaries with unwavering resolve. Join me as we navigate the pharmacological landscape, guided by the principles of precision and efficacy. Our odyssey commences with a stalwart defender known as linezolid, wielding the sword of antimicrobial prowess alongside rifampin to vanquish the scourge of prosthetic joint infection caused by staphylococcal invaders. And in the face of microbial incursions orchestrated by the cunning gonococcal and gram-negative pathogens, we turn to the indomitable duo of ceftriaxone and ciprofloxacin, sentinels of the joint, standing guard against the onslaught of infection. Yet, in the ever-evolving landscape of antimicrobial warfare, we find solace in the alternative armamentarium of cefixime, a beacon of hope for those embroiled in the battle against gonococcal and gram-negative pathogens, offering respite in both intravenous and oral formulations. As we confront the relentless advance of MRSA, we invoke the power of oxacillin, a potent weapon in our arsenal, capable of driving back the tides of infection and restoring equilibrium to the joint. And for those ensnared in the clutches of MSSA and ampicillin-resistant enterococcal pathogens, we extend the olive branch of vancomycin, a stalwart ally in the face of penicillin allergies, offering succor to the afflicted and reprieve from the ravages of infection. Last but not least, let's delve into the crystal ball of prognostic indicators for septic arthritis. We confront a landscape fraught with uncertainty yet punctuated by rays of hope. Join me as we navigate the terrain of patient outcomes, guided by the beacon of early diagnosis and vigilant treatment. Our journey commences with a testament to the resilience of the human spirit, a testament that echoes through the annals of medical history as patients who receive prompt diagnosis and timely treatment emerge victorious, their joint health restored, and their spirits buoyed by the promise of a brighter tomorrow. Yet, amidst the triumphs of proactive intervention, we confront the specter of permanent joint damage, a specter that looms large in the shadows of delayed diagnosis and inadequate response to antibiotic therapy. Joint degeneration emerges as a harbinger of complications, a stark reminder of the toll exacted by the relentless advance of infection in the absence of timely intervention. And yet, even in the face of adversity, we find solace in the resilience of the human body, a resilience that perseveres in the face of adversity, steadfast in its pursuit of healing and restoration. As we chart our course through the ebb and flow of patient outcomes, let us heed the clarion call of early intervention, for therein lies the promise of recovery and renewal, a promise that transcends the boundaries of adversity and paves the way for a future imbued with hope and possibility. As we draw the curtains on this enlightening session, let us reflect on the journey we have undertaken together. A journey through the intricate labyrinth of orthopedic infections, where each twist and turn has revealed new insights and revelations. Throughout our exploration of osteomyelitis, septic arthritis, and their myriad manifestations, we have delved deep into the heart of diagnostic challenges, treatment modalities, and prognostic considerations. We have navigated the treacherous waters of risk factors and complications, armed with the beacon of knowledge and the compass of compassionate care. Thank you, each and every one of you, for your unwavering commitment to the pursuit of knowledge and the noble cause of healing. May our paths cross again in the pursuit of excellence as we continue our collective journey to brighter horizons and better tomorrows.